So welcome everyone. My name is Claudia Ellison. I'm Director of Programs, and I want to welcome you to today's EHI webinar, Pulse on the Industry, Interoperability, and Population Health Management. I just want to, first, we've got oh my goodness, we've got this is a project that EHI had done. It's, we interviewed several people, and today we're going to be discussing the results of these interviews, followed by a facilitated discussion and hearing perspectives of folks from CORHIO, Robert Denson, and Morgan Hanea, and also Laura McCrary from KHIN, and the conversation will be facilitated by Heather Hallett of Medicity. So before we get started, just a few housekeeping rules. All the participants are muted. We've got two boxes on this webinar. One is for chat, and that's if you have any technical difficulties, and the other one is for Q&A. So for any questions, if you could just please make sure that you're focusing on the Q&A box, and what this does is it actually captures the questions, and if we're not able to get to all the questions, it saves them, and we can follow up with you later if you would like. And then today's slides will be downloaded on the EHI website. So just in terms of eHealth initiative, our mission is to really serve as an industry leader, and we provide best practices and aspects of how health information technology is transforming healthcare. We conduct research, education, advocacy, and we convene healthcare leaders such as yourselves in a multi-stakeholder collaborative with our webinars and our executive roundtables, our yearly events, etc. This is just a picture of some of the different different members that we have, and as you can see, it is very multi-stakeholder. We've got providers, payers, vendors, consulting groups, etc. And don't forget to take a quick look at our EHI resource page. We really have a lot of information there. It's easy to use, and if you would actually like to submit something, please don't hesitate. It's very easy to put in a request for your document. We'll review it and then add it to the resource. So take a look at that when you get a chance. And this, the slide deck and audio for this webinar will also be added to this resource page. And I also wanted to share with you that starting tomorrow and Thursday, we're having our eHealth Executive Summit. And this is a little different than our normal yearly event. We have decided that we really wanted to make it so that we come out of there with very clear objectives and sort of action items. And we've divided up the participants into 3 roundtables: value and reimbursement, technology and analytics, and workflow for providers and patients. Each of these roundtables is going to be facilitated by one of our board members. And so it's going to be a really dynamic discussion, and if you can and would still like to sign up, please don't hesitate. I'd also like to thank Medicity for the generous support of this webinar. eHealth is a nonprofit organization, and we rely on the generosity of organizations and companies such as Medicity, so thank you. Now, a little bit about the research that we conducted. We did interviews of executives of providers and HIE organizations, really about how they collect and exchange and use data for population health management. And we were really fortunate that we had some fabulous executives who provided their time and expertise, 2 of which are on the webinar today. And although the report didn't provide, really earth-shattering results, I really believe that there's value in confirming some common assumptions about the practice in the market and assurance that we're actually acting on the most current information to inform the industry and policymakers. So here's some of our key findings. So the industry has come a long way, And although there's still challenges, it's it's a process. But the industry is working incredibly hard to meet the requirements for things like value-based care reporting and sharing data to impact both patient and population health. So although there's always challenges, when you think about where what data looked like not too long ago, and the exchange of data, we're making some incredible progress. So, in terms of some of the challenges, I'm not going to actually read the slides, but I think what we will be doing is during the facilitated discussion, we're going to be going over, where the industry, where our panelists think the industry is, where they are, some of their challenges and their successes, and how they're working to overcome some of these challenges. So as we all know, the amount of data, types of data, and uses of data are really continuing to grow. How the data is managed, stored, and accessed is really key. And again, this is a discussion that our panel will discuss, and how they're actually managing this. One of the challenges was that there's so much data, and how we can actually manage the data. And but wait, there's even still more data that we're beginning to accumulate. HIEs are now accessing using these other types of data. For example, social determinants of health, the economic and social conditions impacting health. And for this, the data comes from multiple sources, and state and metropolitan areas, census, CDC, etc. There's a patient-generated health data coming from Fitbit, phone apps, home health devices, etc. And now we're even able to store through an HIE behavioral health data and share it, from providers and payers. And there was huge obstacles to overcome with privacy and HIPAA concerns, but many states are working to overcome this. And then medication adherence, to be able to track who's purchasing. This is combined with the controlled substance tracking. It's just, the value is just amazing, but of course it does include even more data to manage. And now we've got, even today we've got, things just don't seem to stay the same. There's new market trends, and how will these aspects impact your data management? There's open API, the growth of Facebook, the new Apple announcement, and now Amazon coming into play. These are all really exciting, innovative initiatives, but again, it's going to be how you all are going to be accessing and managing this data. So on that note, I'd actually like to introduce our esteemed panel, starting off with Dr. Laura McCrary, who's the Executive Director of the Kansas Health Information Network. And she's also Senior Vice President of CAMCO Health Solutions. Laura but wait, she's also an adjunct professor at Rockhurst University at the Healthsburg School of Management, and teaches courses in health information technology and quality. She was our past chair of the National Policy Steering Committee for EHI, and the payer work group for the Strategic Health Information Exchange Consortium at CHIC, which is CHIC. Laura also served as the co-chair for the advisory board of the Choreo project, and served on the governance group for the National Syndromic Surveillance System. Morgan Honea, and I hope I'm pronouncing your name correctly, serves as the CEO of the Colorado Regional Health Information Organization. Morgan serves in a governance capacity for multiple organizations, and as the representative for HIE on the Governor's Commission for eHealth Innovation. Robert Denson is the CIO, as well as the HIPAA Compliance Officer for the Colorado Regional Health Information Organization. And then last but not least, we've got Heather Hallett, who's the Clinical Vice President of Medicity. And she's really built her career around improving the safety and care of patients through enablement of HIT. She's worked as a nurse, a clinical consultant, a project manager So as you can see, the expertise of this panel is fantastic. So on that note, I'd like to turn it over to Laura. And Laura, I'll move the slides for you.
Okay, thanks, Claudia. I really appreciate the opportunity to spend just a few minutes today talking about KHIN that we're doing in Kansas. And so, Claudia, if you want to go to the next slide, that'd be super. And just click on through and just open kind of all of the animation up. And we'll just talk through this quickly. So KHIN is a private, no, go back one. KHIN is a private health information exchange. It's a not-for-profit started by the Kansas Medical Society and the Kansas Hospital Association in 2010. And so today we're tracking just about 5.2 million patients in KAHAN, which is really pretty good and remarkable in light of the fact that there's only about 2.8 million people that actually live in Kansas. So you really see the kinds of numbers of patients that are moving in and out of the Kansas healthcare market. We do have connections with other exchanges. We connect with our sister exchange, Lacey, which is an exchange that serves the Kansas City metropolitan area. And we're currently connecting with exchanges in our contiguous states. We average somewhere around 9,000 to 10,000 providers using the exchange. You know, many of you know the way exchanges work. You know, sometimes you have practices that are hiring doctors and nurses, and sometimes you have practices that are closing. So it sort of goes back and forth a little bit between about 9,500 to about 10,000. We have about, we have close to 1,300 different healthcare organizations that are in production, not just members that are in production. And we actually can support all of the IHE protocols, XDS.B and XCA, as well as HL7 V2. And then we also do public health reporting with HL7 V2.5.1. We average about 120,000 HL7 messages daily. We have about 126 hospitals that are connected and sharing data in Kansas, which is pretty good. It's about 98% of all of our hospitals in Kansas are connected and sharing data. And we also receive about 9,000 CCDs daily. And we'll talk a little bit about the management of those CCDs as we go through the presentation. But we do really have a significant number of CCDs over the years that we've been collecting and storing data in Kansas. We average somewhere between 15 million and 20 million CCDs. So we've got a lot of data that's moving through KHIN, and a lot of management of different types of messages, different types of connections. So HL7V2, XDS.B, XCA. We also support XDR connections for direct messaging. And we have a variety of different public health connections that we support through HL7 2.5.1. Claudia, let's go to the next slide. One of the things that we learned over the years is that the data that's coursing through the Health Information Exchange has a great deal of utilization at the point of care, but also it's very applicable when you start to aggregate that data to be able to use it to provide information back to our doctors. So about 3 years ago, we began the establishment of an enterprise data warehouse and worked closely with a number of our hospitals in Kansas and physicians in Kansas to begin to develop a way to aggregate that data for a doctor or a hospital so that they could look at their patients in a panel rather than having to open up the Health Information Exchange and look at one patient at a time. And so working with our hospitals and doctors, we identified a series of analytics that they would really feel had value to them as they were either getting ready to move into value-based payment models. At the time, you know, we were just beginning to contemplate the ACO and the ACO models. The MSSP track 1 models were just starting to emerge, but we could see on the horizon that there were going to be lots of opportunities for other value-based payment models, and that our doctors and hospitals were really going to need to be able to aggregate the data that was coming through the health information exchange. So today you can see the different dashboards that we have for our doctors and hospitals, and they really are designed and built around what our doctors and hospitals ask us for. So just to quickly go through these, high-risk patients is really those patients that have 3 or more chronic disease conditions and have had 5 or more ED visits in the last 12 months. Quality metrics is really focused on patients that have care gaps. So not only those that have actually received care, for example, their breast cancer screening, those that have not gotten their breast cancer screening, or those that maybe have gotten their breast cancer screening but haven't had their wellness visit. So it really helps our doctors that are reporting for MIPS. And so it's really designed to be a way for our doctors to know what's happened with their patients across all of the providers that are participating in the exchange. Readmissions is just exactly what it sounds like. This is the patients for a practice or for a hospital that have been admitted into the hospital, and then they've readmitted into either that hospital or another hospital within 30 days. Disease registry is really just designed to provide a list for our doctors and hospitals of their patients that have specific disease conditions or specific lab values that would put them at risk or at high risk. For example, patients that have an A1C value greater than 9, or rising risk patients that have an A1C value between, say, 5.4 and 6.7. We do focus on behavioral health. KHIN has been sharing behavioral health data since 2012. So we have a little bit of behavioral health data, and really now we're focused on the behavioral health metrics so that we can start to identify those patients that have severe and persistent mental illness, but maybe didn't have a suicide assessment, or children that have not had suicide assessments. We look at utilization broadly. How many patients of yours, when I say yours, I mean a practice or a hospitals, have been admitted into the emergency room in the last 24 hours, in the last 48 hours, or into inpatient services. Controlled substances, this is the number of controlled substances or opioids that have been prescribed for a particular patient or administered. So I'm not going to go through all of these, but you can see we also focus a lot on trying to attribute patients to providers. We've attacked the attribution problem pretty aggressively, and then we serve as a QCDR for our doctors so that they can actually report through us for their MIPS reporting. So you can see the last slide there is the ACI-IA, the Advancing Care Information or Improvement Activities Attestation. You go ahead, Claudia. This is just an example of the thing that we're working on now that's probably most important to us, which is really to go ahead and become certified with NCQA and ONC to be able to compute the eClinical quality measures. These are the measures that we're currently certified for, and we will be getting 14 additional measures certified this year. And what this allows us to do now is to run the ECQMs across all the data in the exchange, rather than just across the information in the one EHR system. So we think this is sort of a game changer in terms of the things that we do, because we know that patients get care in many, many places, and that in fact that the quality metrics, similar to what's done with an ACO, that the quality metrics actually ought to be calculated across all of the locations that the patient has received care at. And now that doctors are being not only evaluated but paid based upon their quality measures, we know how important it is for doctors to have the highest quality scores. So computing the measures across the exchange is going to become critically important as we move forward. So I think that's my last slide, Claudia. Anything else?
No, thank you very much. And of course, you'll be part of the facilitated dialogue, so don't go away. Now I'd like to turn it over to Choreo.
Thanks, Claudia. So this is Morgan Honey and Robert Denson calling from Denver, Colorado. The mountains are covered in snow today, so I hope everyone's enjoying this cool weather. Just a quick overview of Choreo. As a health information exchange, we are, just like Laura mentioned, a 501c3 nonprofit, locally controlled and governed by stakeholders here in Colorado. Today, our network is about 5.4 million patients. We have about 11,700 users of our provider portal and 4,900 non-hospital-based providers in the network. They account for approximately 47 million interactions. We count those weekly, so pings on our provider portal come in about 900,000 a week at this point. We also send out about 115,000 notifications weekly and push about 125,000 patient results into EHRs for that workflow consistency. Our network is made up of 64 hospitals, 9 labs, a pretty large network of ambulatory and non-hospital-based provider settings. And then we manage about 375,000 clinical transactions on a daily basis. And then we have about 1.5 million ambulatory care summaries available. So Claudia, click to the next slide, please. So this is just an overview of what our network looks like here in Colorado. Interestingly enough, for the folks on the phone, Colorado is a largely Epic state. And so as we talk a little bit about the findings of the survey, it'll be interesting to talk about how the vendor dynamics add to challenges or solutions. But you can see here, and all of this is available on our website if anyone's interested. Go ahead and click ahead. Again, these are the folks that are in the process of connecting, hopefully one day, in some level of discussion right now. You can click ahead. And then for all of you who are interested in going and learning more about who we are and what we do, our website is a really good resource for finding what locations are in the HIE, who's participating and what type of organization they are, and lots of great resources out there for folks who are interested. Of course, if there are any questions about Choreo following this presentation, you're always free to reach out to Robert or myself.
Well, thank you both, Laura and Morgan, for sharing a background and grounding us for today's discussion. Just a quick question about your organizations. Would you both be able to share a little bit about your future vision? Laura, maybe we can start with you. I mean, you have a lot of initiatives in place, but really, what is your vision for KAHAN moving forward?
Well, thank you. You know, it's interesting that, you know, to kind of think about that. The state of Kansas is just about fully connected. Most of our hospitals are connected now. 70% of our physician practices are connected. You know, we've been building this for, 8 years now, and we've really hard to get most everyone connected. So we are moving away from our focus really being on the interoperability side of the business and really moving forward very aggressively to focus on education and outreach. So how do you actually use the health information exchange if you're in a value-based payment model? How do you use the analytics products? How do you use alerting? How do you really integrate that into your workflow and into, your care coordination model? So we are just now in the process of hiring our first 2 education and outreach coordinators that will really go out and talk with our practices and our hospitals, particularly our doctors who are, now reporting on MIPS and have to really think about things a little bit differently as they look at the advancing care information requirements and the improvement activities. So our focus is shifting, and it's kind of a pivotal time for us because we do have the connectivity piece really pretty much taken care of, and now we really need to focus on how to best utilize the information and the data flow and the products and services that we have available. I'd say the other key issue for us is data quality. We've spent so many years just trying to get the connectivity done that we didn't really pay that much attention to the quality of the data that we were bringing into the exchange. We looked to make sure that labs were coming in and medications were coming in correctly, but we didn't look to see that all of the data that's going to be necessary for our customers to be successful in value-based payment models, was actually in our data feeds. And so now what we find is we go back to really look at analytics, we'll find, oh gosh, we're not getting, the diagnosis codes out of the emergency department for this particular hospital. And that's really affecting their ability to, use the data for value-based payment models and for reporting. So it's both of those things for us. It's a focus on data quality. and quality metrics, and it's a focus really on education and outreach to our customers.
Thanks, Laura. Morgan, over to you. Can you share a little bit about Chorio's strategic direction and vision moving forward?
Sure. So I would echo a lot of what Laura just said, with one exception. I would say that there's still plenty of work for us to do in terms of data acquisition efforts. And so a foundational component of our strategy will always be to grow the network. That may be additional ambulatory information, that may be specialists, like you mentioned earlier, self-reported data, social determinants. So we're always going to be out there on the ground with an eye towards new and growing data within the network. Then right in the middle, what I call kind of midstream investment is how do you get that data into a format that's usable for the most services and products possible. Because at the end of the day, our clients are varying, they are diverse, they come from many different backgrounds, and they have many different use cases. And along with those use cases, they also have a variety of tools that they use. And all of them want to be able to have access to the largest data set possible in a manner by which is clean, normalized, harmonized, and accessible within their native work experience. So whether you're working in Epic or NextGen or NetSmart or an Optum analytics platform, so a care management platform, everyone needs similar data in different fashions in order to do their work. And so our midstream investment is all about normalization, harmonization, workflow integration. And then obviously, I think there's a big push here in Colorado, and I know everywhere else, that we've got to get beyond the four walls of healthcare in order to solve for health outcomes. And so how do you begin to integrate social determinants, behavioral health, and substance use into this variety of different healthcare professionals and their workflows, all the way from administration of ACOs down to front desk and reception type of roles. So that's where we're headed, and certainly I think we've got plenty of room for improvement, but a lot of great learnings under our belt as well.
Thanks, Morgan. And I'd like to further discuss the topic of data and data acquisition, and maybe we can even engage Robert in this piece, because I know he's intimately involved in acquisition of data and the efforts to do so. You alluded to it earlier in your overview of Choreo about which types of data that you receive today. Can you provide more detail about the types of data that you receive today, whether it's real-time or retrospective, challenges that you have with obtaining the necessary data for purposes of use either at the point of care or for consumption by downstream systems?
Yeah, you bet. So here at Choreo, we get data in a number of different formats, which does cause a lot of challenges as well, especially as we continue to grow the network. You know, you have your standard HL7 interfaces. We're also receiving CCDs from clinics around the community. And, you know, where HL7 is relatively standard, I'd say we're seeing a lot of differences, even though there is a HL7.org structure around CCDs. Every EHR vendor is a little different in how they're using it with their own workflows. So, you know, the data that's coming across, and even there's some issues with the structure of those as well. And so we're continuing to take data that way. You know, as Morgan discussed around, you know, social determinants of health and even behavioral health, you know, we're looking at even a CSV file and how you intake that. So those are some of the primary ways that we're ingesting data. And then obviously IHE profiles with CCD exchange is another method that we're receiving CCDs rather than just having them incoming on our platform. So really a lot of challenges we see around those different data and HL7 formats. So as we kind of, as Morgan alluded to our strategy, cleaning up data, we're looking at ways where we can normalize all the data that's coming across from those different systems and provide them and serve them up to the community in an easily read and usable format and consistent. That's probably one of the key pieces as we move forward.
Thanks, Robert. Laura, do you have anything to add? Are you seeing the same challenges with data? I know that Robert mentioned the structure of the CCDs and how it's coming in variations, and so this is proposing a challenge. Do you have anything to add?
Well, yes, that's always been a challenge. Each EHR vendor has a little different way that they either compile the data into a CCD. We look at the CCDs to determine whether they're complete. When they come into our exchange, we use a product called CCD Analyzer, and we look to see whether or not the CCDs are complete when they're coming into the exchange. We also look to see if they're correct. So we examine the completeness and the syntax of the CCDs. We work directly with the EHR vendors and with the customer, the client, to try to get as much data and to have it as accurate as possible. But I would agree with Robert, until recently, we have really not been able to provide consolidated CDAs. So this is where you really take all of the CCD information from all of the CCDs that are coming into you. You take all of your HL7 data and you compile it together into what's called a consolidated CDA, so that you're providing one deduplicated, normalized document to the end user. And so that's really been our focus for the last 2 years, is really to be able to work with our vendors and be able to deliver a document to the end users where they can actually see all the data from all of the different facilities, whether it's HL7 or CCDs, XML, and then be able to choose what it is that they actually want to look at. So, for example, many people don't want to look at an entire consolidated CDA. What they want to look at is the medications, the allergies, the problem list, and the procedures. And in most cases, some others just really want to look at the plan of care. And so what we're trying to provide to our customers is the ability to have one document that incorporates all the HL7 data, all of the CCD data, and is configurable based upon what it is that our doctors or our hospitals really want to see. So we are very close on that, and we think it's really a game changer in terms of being able to provide the kind of data back to our doctors and hospitals that they really need in a quick and consolidated manner. But I will say it's been a long time coming. We're 8 years into this, and we're just now really in a place to be able to provide information back to the doctors in the way that they really want to see it.
At this point too, Laura, do you feel that the content, the actual codified data that you're getting in those CCDs and that HL7 stream is enough to support point of care physicians or support your analytics types of initiatives? Or do you still feel that there are some gaps relative to data that you're not receiving today that would be helpful for them in treating patients, or furthermore for you doing an analysis to help them with better outcomes?
Well, I will tell you that the data that we receive in the CCDs, when it's also complemented with HL7 data, is pretty complete. And it really has proven to be much more robust than we ever thought that it was. And as you start to parse that data and put it into your data architecture and actually try to answer the questions that our doctors and hospitals are posing to us, it is amazingly robust. Now, there's still a little bit of data that I think that we could glean out of natural language processing. And as those of you on the call know, NLP is still in its infancy, and particularly as it relates to the reports that are coming across to the exchanges. But I think that's sort of the next area that we will be delving into, is to really identify with our doctors and hospitals what are the key components that are contained in those reports that we're going to need in order to really round out our analytics so that it's a complete set of data. Really, honestly, the only thing that we don't have is the financial information. And so that's really where we partner with our organizations to include the claims data to be able to provide that complete look at what's happening with the patient. So I would honestly say the data that we receive between the CCDs and the HL7 data is far more robust than it's coming in on claims or that anybody's getting really anywhere else, and it's near real time. So we know the patient was in the emergency room last night. Claims, aren't going to reflect that for another 30 days.
Well, I'm sure that all of our participants today are comforted to hear that there is such robust data combining HL7 and CCD today to support their needs. Choreo, do you experience the same thing? Do you feel that the data is robust enough to support point of care and as well to support your pop health initiatives moving forward? Do you have anything to add?
I would agree with what Laura said. I would also emphasize that technology is only one part of the solution, and workflows and transformation support are critical to making sure that you're using the right mechanisms for the right measures. And so we have a team that we transformed from the old Regional Extension Center program into practice transformation coaches with a specialization in health information technology, who are out in the field every day working with clients to improve the way that their data comes into and out of their systems so that they can get the most value out of their HIE participation as possible. And so I would just emphasize that there are plenty of technology solutions out there to do this work, but probably the biggest challenge and the biggest component necessary for doing it correctly is having those folks in the clinics that can help with workflows and data entry and consistency.
So that's definitely a best practice. Any other words of advice on your end about how data should be acquired or cleansed or normalized from a best practices perspective? How do you work with your data contributors to really assure that you're getting quality data coming into your network?
Yeah, and Robert can speak to this very eloquently. I would tell you that, and I tell folks all the time, one of the reasons that Choreo, in my opinion, is as successful as it is because we try to keep the barriers to entry fairly low on the onboarding process. And so we really want people to participate. We want them to contribute data, and which means that sometimes we're a little lax on the standards. We would much rather take an approach of going back to the practice or in the process of implementation, cleaning up that data. But once we have it inside our system, we also do a tremendous amount of work to normalize it and standardize it and harmonize it. So, it's always a challenge of, do you create barriers to people participating in the HIE by having too strict standards up front, or do you create the opportunities to work with them after the fact, apply technologies kind of midstream to do the work in a central location, and then work to clean the data as time goes on? I mean, I think we're probably leaning on all three legs of that stool, but certainly having feet on the ground out there is a priority for us. Participation in payment reform initiatives is critical because there's value in that for providers to participate in these programs. And then, then kind of the third leg is that midstream technology to standardize and harmonize. I would also say that one of our major strategies that we haven't talked about yet is where are we going with APIs and moving away from custom interfaces for this type of exchange. And certainly that's high on our priority list as well. We think that some of the work we're doing with FHIR right now in coordination with the consolidated CCDs and the ECQM type of work that we're doing is really going to revolutionize the way we do this work going forward, and hopefully significantly decrease the cost for everyone involved.
And just to add on to what Morgan stated, I mean, here, as he stated earlier, it's a heavy Epic system out here in Colorado, and Epic is not Epic, in each implementation, and even within facilities in the same Epic installs, we're getting different codes for the same, intent across those systems. So, really that's where I think the power in the HIE and the value comes in, is being able to do the normalization of the data incoming and not leaving it to each of those systems. You know, probably most of the folks on this call have seen it. Those systems change values on a regular basis without informing anybody. You know, they have their own internal workflows, and that's what they worry about, and that's what they should worry about. So my value to the community is being able to take all this different data with all the same meaning but different codes, normalizing it into one standard code. And, you know, we have a quality shop here within my team that does it very well, and, you know, works. You know, the key is knowing the intent of the meaning for that value, but not necessarily having to code it specifically for them. We can leverage other technologies that are available, and we don't have to be the experts there, but we can be the facilitator. And I think that's the true power of the HIE.
Fantastic best practices and commentary on how to reduce barriers to joining your clinically connected community. I'd like to know, Laura, do you have any other best practices that you'd like to add relative to data acquisition, data quality, etc.?
You know, the only thing I would add is the importance of being able to maintain the HIE within the workflow for the doctor. And what we really try to do in every possible instance is to build an XDS.B or an XCA connection, either with Epic or Cerner or Allscripts, any of the EHR vendors that support that, so that they are querying the exchange, you know, at midnight or at 2 a.m., pulling the information back on any patients that are registered in the next day. And then for those EHR vendors now that have 2015 certification, you know, the data from the exchange is actually populating the patient chart. And we have been seeing that now with the new 2015 certified EHR products. So for many of our doctors, particularly those with sophisticated EHR systems, you know, it's become a seamless process for them. They really don't even know the exchange is operating in the background and the data is in the patient's chart rather than having to be re-entered. So I think that, you know, from our perspective, you know, our goal is to keep our doctors within their own workflow, not having to go out to a portal or to go to some other site. And so our preferred integration model is XDS.B with an ADT feed for a hospital and XDS.B for any sort of ambulatory practice. But we find that about half of the EHR vendors out there still can't support the IHE protocol, so we sort of have to resort to the HL7 data feeds. But our goal is to keep our doctors in their workflow.
Fantastic. And you also mentioned earlier about your role in supporting PHM. I really just felt that your comments were very strong, and I was hoping that you could just recap them and provide all of our participants today a summary of your role in supporting population health management at KAHAN.
Well, thank you for that. I appreciate it. You know, as I said, we work very closely with our doctors and our hospitals to try to build the products that they need in order to be successful. So, as I mentioned at the very beginning, we are an HIE that's governed by the Medical Society and the Hospital Association in our state. And to that end, we have a lot of input from our doctors and hospitals in how they would like to be able to receive the data. And just looking at one patient at a time is certainly not going to be adequate for them. And so what they really requested is that we build dashboards that would allow them to be able to look at the data for all their patients in an aggregate view. And so it's the payment environment changes, the responsibilities that our doctors and hospitals have in order to be able to meet those requirements are ever increasing. And so as the population health management component of whether it's the improvement activities for MIPS or whether it's still the continued meaningful use activities for the hospitals and those providers that provide, a large amount of services to Medicaid populations, we we find that those population health metrics are extremely important to our doctors and hospitals. They need to know what parts of their community really have the largest number of patients with chronic disease conditions so that they can really work as a part of the community to implement wellness initiatives, diabetes education programs, weight reduction programs in different parts of their communities. So you have to be able to look at that data in an aggregate sense. And you have to be able to look at the data in the real time. You can't wait for the claims data to come in. And I think that's been the misnomer, that so many people have fallen into, is that they think that by using the claims data that they can really actually predict what's going to happen with the population of patients that they have. When in fact, that really is just one piece of the puzzle. And in fact, if you don't have the near real-time clinical data that's coursing through the veins of the health information exchanges, you really don't have the most important data. And so, I'm more than happy to talk to folks about how that health information exchange data can be harnessed and aggregated and put into dashboards that really can provide the very best information for all of our doctors and hospitals across the nation as they move into value-based payment models.
Appreciate you reiterating the value proposition of HIEs in support of PHM. Choreo, Morgan, Robert, anything else to add on your end before we start taking some questions from our participants?
I won't take too long because I want to make sure questions get answered, but I appreciate everything that Laura just said, and from my perspective, the infrastructure that's been built at the HIEs is an incredibly tool that should be leveraged for multiple purposes in population health management. I mean, if you think about it, at our core, we're a high capacity, real-time data integrator and aggregator. And when you talk about how to start tackling issues with social determinants, you need things like identity management solutions, integration solutions, different and quite frankly, innovative database structures in order to leverage that data to the nth degree. And so I really try to preach here in Colorado that when we talk about continuing to integrate into social determinants, bringing in different care settings and engaging different types of communities and providers and caretakers, that leveraging the HIE is the smartest thing we can do, because the investment that's been made here in those tools can be used in a modular fashion to get the most value out of all of that data and continue to expand the scope and the use cases without having to start from scratch every single time.
Well, thanks, Morgan. Yeah, okay. So let's move on to some of the participant questions. And the first one is really relative to your business models at KAHAN and Choreo. They were just really interested whether or not you were state funded. How did you get started? What is your business model? How do you maintain sustainability? It's really kind of just a little bit about your organization. So if you could provide a few comments there, that'd be great. Maybe Morgan, we can start with Choreo.
Sure. So like many HIEs, we were a product of ARA high-tech funding. And so we were capitalized through that funding mechanism back in 2009, 2010, really with the goal of building a subscription model that was palatable for our major stakeholders. And so early on in the organization's history, we sat down with the hospitals and the payers and all of the folks that would be involved, came up with a business model, with a pricing model that was reflective of what they felt the value would be on an investment like this, and over time have continued to grow that subscription model. Today, our revenues are a blend of contracted work that we do with the state, leveraging the 90/10 and IAPD funding opportunities that then translate into products and services that we turn around and charge subscriptions for to create that ongoing revenue trail. Today, I have $0 in grants, and we're completely self-sustaining with our subscription model and our contract work that we do with the state of Colorado.
And Laura, the inception of KAHAN, can you provide us a little background?
So I would say that what Morgan said is very similar to the way that KHIN is built. We are a subscription model. Everybody pays a little bit. And so our goal is to keep the costs as low as possible because everyone contributes. We also have payers as our members. We have contracts with all of the major national payers as well as with our local payers. They also pay to participate as well as to be able to gather data for their reporting. And in addition to that, we are in the process now of providing data analytics to medical researchers that are utilizing the data for research on medical breakthroughs that they are working on in a variety of universities all across the nation. So we have a wide variety of really monetary and fiscal resources that we can draw from. We also do not take any grants. We are fully sustainable and actually are a little bit better than that this year. And so we are really focused on making sure that we upgrade and all of our technology to the latest versions for our doctors and hospitals, and really stay focused on providing the best products and services for everyone.
Okay, and Laura, the follow-on question from this participant was around a minimum data set or fields that you require from each of your stakeholder participants. They're wondering if you do request a minimum data set. And to add on to that, another participant said, well, what about public health and the contribution of data from public health or social determinants of health coming into the network? Are there minimum requirements from your HIE's perspective to onboard?
That's an interesting question. The state of Kansas actually was a little bit different than most states in the way they actually set up the HIE structure. The state of Kansas certifies exchanges to do business in the state. And so you have to apply for a certificate of authority to do business in Kansas. And as a part of that, you have to meet specific requirements that the state has set up, both around a minimum data set as well as the transport and the receiving of public health data. And so there is a minimum data set that the state of Kansas has. The truth of the matter is, though, Kansas has never forced their exchanges to adhere to that because there's such variability across the EHR vendors and what they are capable of sending. I think we're getting farther along in terms of interoperability and the capabilities of the EHR vendors, but Kansas does have a minimum data set. It's just that it's never really been enforced by the state. The second is that we do have a responsibility to not only send public health data to our state, but also to receive it and to make it available. So currently for Kansas, we serve as the proxy middleman to be able to take the messages from the EHR vendors and to transport them in the appropriate format to the state. So we do that for immunizations. We do it for syndromic surveillance. We do it for electronic laboratory. And then we also create unique registries for our state based upon the requests that the state makes. So for example, we also have a birth defect registry because our state requested that, and we have an infectious disease registry. So we also receive data from the immunization registry back, and we make that data available not only to the providers, but also to the patients, because we have a personal health record that's connected to our health information exchange that provides all of the data from all of the health information exchange back to the patients, as well as a certified copy of their immunization record, so that the state doesn't have to have that responsibility. So both of those things are really important to us from the perspective of being able to meet the requirements that our state has established for us.
Robert, Morgan, are there also requirements around minimum data sets in Colorado, or does this differ from Kansas?
I think we're very similar, that we really have tried to go down the route of a gold standard for the state, especially, when we're exchanging data with other HIEs. That becomes even more important. But, as Laura talked about, there's challenges with the EHRs, where they're at, and, we don't want to end up being a roadblock of people being able to provide data. So, we work around those, so our vendors are very flexible in being able to take the data they have, and and I think it's a evolution of what the EHR vendors will do. So what they can do today, we'll go back to the contacts we have with the vendors and continue to try and improve what's coming from those coming from them from a data perspective, and then also, as Morgan talked about, sending out where we can our folks in the TSS realm to work with the practices on workflow, so they're not working around their EHR to capture data. They're working with their EHR. We think we'll see some good success in that strategy.
Okay, and public health data as well. Are you receiving public health data either from registries or from public health providers in the Choreo community?
We do. So we receive immunizations for practices, and we send those to the state. We have built a query with the state as well, so folks can query through us to pull immunizations out of the state repository for immunizations. We do syndromic surveillance and electronic lab reporting. So we have a number of public health interfaces at this time that we send and receive data from our platform.
There's also a big push right now to give public health providers access to a shared EMR system. And so we're also setting up a connection with that shared EMR platform that will then contribute data back into Choreo from those local public health folks that are in the field.
Interesting. And by the way, I think everybody is interested because there are a lot of questions that came in. I just wanted to let all the participants know that if we don't get to your question today, we will be summarizing them as well as working with our panelists to answer your questions, and we'll be sending them out post-webinar. So another question about data, and specifically behavioral health data. The question is really around segregation of the data or limiting use to access of the data. Maybe Laura, you could talk a little bit about what you're doing there, or if there's anything specific relative to KAHAN around sensitive data.
Yeah, so we've been sharing behavioral health data since 2013. I think we were the first exchange that actually started sharing behavioral health data, and we've been sharing substance abuse treatment data since 2014. We went through a process with SAMHSA and with the National Association of Community Mental Health Centers to make sure that we actually were meeting all of the requirements. And I will say this is, for those of you who know me, you'll know this is common, that I always say, let's not let perfect be the enemy of good. And I will say that what we're doing around behavioral health data, while it's good, it's not perfect. And we still have a lot of work to do. So one of the first things that we did in Kansas is that we normalized all of our HIPAA, we normalized all of our patient consent laws with HIPAA. And because we, like many states, the folks who are listening, we had all kinds of patchwork of laws related to patient consent around sensitive information. And so that had become so problematic that we couldn't actually be effective as a health information exchange. So in 2013, our legislature passed a series of laws that normalized all patient consent with HIPAA. So that was a huge help. And then we were able to share behavioral health data, not substance abuse treatment data, because that's covered under federal regulations under 42 CFR Part 2. But in terms of the rest of the behavioral health data, we were able to share that. And of course, we have an opt-out process in Kansas, so patients are in the exchange unless they take proactive action to opt themselves out. And so if they don't want their behavioral health data to be shared, then they can opt themselves out of the exchange. The process in terms of sharing the Part 2 data was even more complex because we have so many facilities that are coming onto the exchange on a regular basis that we that we could ever meet the requirement of notifying and getting permission from the patients every single time we added a new facility that was either sharing data or accessing the data. So we, the way we manage that is that the data related to substance abuse treatment is sent to the exchange, but it's blocked. And then it's only made available at the point of care with the patient's direct consent. So the patient signs a form, and then our doctors can override the security on the exchange because the patient has indicated consent for that doctor for that particular period of treatment to override the security on the exchange, and they can look at the information with the patient's consent. The other thing that allows, though, is under HIPAA, the doctor can look at the data if it is a medical emergency. And so because the data is in the exchange, even though it's blocked, if the doctor determines that there is a life-threatening medical emergency for the patient, the doctor can override the security on the exchange. And we have had that happen in multiple cases where doctors have felt like it was life-threatening. They've overridden the security on the exchange. We get an immediate alert that the security for a patient that has either opted out or has sensitive information has been overridden. We contact the facility that the individual belongs to that overrode the security, as well as contact the substance abuse treatment center to let them know that this occurred. So we feel like we have a process in place that has saved lives of patients. But it is not perfect, and we're looking forward to the opportunity to all work together as a community of providers to do even better ability to parse sensitive information. But we know that what we've put into place has saved patients' lives. So it's not perfect, but it's something.
Thanks. And unfortunately, we can't go on because we were up on time. But as I mentioned, there are a lot of questions that still remain specific to quality initiatives and other types of use cases and how you can leverage the data to support population health management. So we will be consolidating all of the questions, answering them, and sending them out to all of our participants today. I'd like to thank our distinguished members today of our panel for attending today's webinar and providing such insight to us. And with that, I'd like to pass it over to EHI to close us up.
So again, Heather and the rest of the panel, thank you so much. This is just a wonderful discussion. And I know that we've got just a huge amount of questions. So we will be following up with you. And then we'll also be adding the PowerPoint, which includes the audio on our resource page. So you can, if you've missed something and you want to go back to it, you can access it on our resource page. So on that note, I want to thank everyone, the panel, and also the participants, and wish you a good rest of the afternoon.
Thank you.
Thanks everyone.